Bismillah ar-Rahman ar-Rahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. It is one of transplantation meetings. And today we are pleasured and honored to have the moderator of this session, Professor Ayman Rifai, the ESNT president and the ESNT transplantation chapter president and professor of nephrology and medicine, Mansoura University, and the vice president of Mansoura Kidney and Urology Center. He is the moderator today, and our speaker is one of the great speakers, young speakers, young in age, but very great in his lectures and his science, Professor Mohamed Kamal Nassar. He is the associate professor of medicine and nephrology, Mansoura University, and one of the heads of Nephrometabolic Forum in Egypt, which is recently formed by a very intelligent and distinguished group of nephrologists in Egypt, similar to Professor Mohammed. They are young in their age, but great in their science and great in their care and great in their presentations and expressions and their patient care. Our topic today is one of the very challenging topic: how to address recurrent urinary tract infection pre-transplantation, how to properly diagnose this problem and to deal with this problem pre-transplantation to ensure a safe environment for the transplanted kidney. Before I leave, I would like to thank Dr. Rami Abu Bakr, who is our coordinator today. He is the fellow of MRCP fellow at IMPRA, and he is the fellow of Egyptian Fellowship, and he is World Kidney Academy transplant fellow. And Rami is a transplant consultant in ESNT, and I am really pleasured and honored to have him with me in working in CME chapter activities, and he is willing, in spite of all of his activities, to manage these activities in ESNT. So I would like to thank him so much. Please, Professor Ayman, start this session, and we come to you after the lecture for the discussion. We'll leave the discussion after the lecture as you. Please, Professor Ayman, start.
Thank you, Professor Yasser, for your kind introduction. And actually, it's my pleasure to introduce a dear colleague, friend, and brother, Professor Mohamed Kamal. Professor Kamal is now one of the stars in the medical education, following the steps of our beloved late Professor Hussein Shaisha. I do thank him for choosing this important topic, the urinary tract infection evaluation prior to transplantation, as the urinary tract infection before kidney transplantation can be a serious issue, actually, potentially impacting the transplant eligibility and graft survival and increasing the risk of post-transplant complications. So I think thorough evaluation and treatment of UTI, as well as addressing any underlying conditions, are crucial steps before kidney transplantation. We are expecting to have a very practical, and from the title that this is a case-based discussion, I think we are going to elaborate all the causes and maneuvers that should be performed to delineate and to prevent the post-transplant urinary tract infection, which is the most common infection post-transplant. I will leave the floor to Professor Kamal to start his presentation. Please, Professor Mohamed.
Bismillah ar-Rahman ar-Rahim. Thanks, my dear Professor Ayman, for this kind and great introduction. Actually, it's my honor to be here for the third or the fourth time with the CME chapter, the Egyptian Society of Nephrology. And I want to thank Professor Yasser for his enthusiasm and continuous introduction of these scientific meetings. Actually, it's a great honor to be here also. Today, inshallah, we will talk about clinical challenges in kidney transplant preparation, focusing on recurrent urinary tract infection. What's meant by recurrent urinary tract infection? It means at least 3 episodes in 1 year or at least 2 episodes in 6 months. Recurrent urinary tract infection can complicate kidney transplant preparation and post-transplant outcomes as they may lead to a delayed listing, increased morbidity, as they can cause graft dysfunction, sepsis, or systemic infection in immunocompromised patients. And of course, the problem of antibiotic resistance with the frequent use of antibiotics can lead to multi-drug resistance, complicating the treatment, especially post-transplant. Recurrent UTI before transplantation is one of the important risk factors for urinary tract infection in the kidney transplant recipients. And according to this study that divided the transplant patients to 3 groups, the first with no UTI, the second UTI but not recurrent, and the third the recurrent UTI, this study assessed the effect of this classification on the outcome, including allograft function, rejection episodes, and patient survival. As we can see here, the lowest survival was for the UTI recurrence, the lowest patient survival, and also the lowest graft survival was for UTI recurrence. So it is a big problem, can be associated with major or bad outcomes or worse outcomes in the patient after kidney transplantation. This is the suggested approach for the recurrent UTI in kidney transplant recipients. If the patient had recurrent episodes, you should assess the post-void residual urine, ultrasound and CT scan, and evaluation of prostatitis. If there is any structural abnormality, they should be corrected by surgery. Cystourethropy. If there is vesicoreteric reflux present, you can consider surgery or injection. And if there is no vesicoreteric reflux, you should perform the urodynamic study. And if the bladder dysfunction is present, it's medical treatment. And if there is outflow obstruction, it should be corrected by surgery. Okay, so let's start with cases. We will have 4 cases, and I think we can have a stop after each case to discuss each case and the appropriate decision in each one of them. Let's start with the first one. This is a 55-year-old female with history of type 2 diabetes for 20 years and CKD stage 4. Presence with recurrent urinary tract infection. She had 4 episodes of UTI in the past year, each requiring antibiotic treatment. She is currently being evaluated for a kidney transplant due to progressive CKD. Her diabetes is poorly controlled. A1C is about 8.5%, and she has diabetic neuropathy and retinopathy. She denies any history of nephrolithiasis or structural abnormality of the urinary tract. Of course, we have many concerns in this patient during the transplant preparation. At first, of course, it is a big problem. The recurrent UTI is a big problem. Diabetes is also associated with poor glycemic control due to many factors, as we see. The CKD stage 4, advanced CKD itself complicates the management of UTI due to altered pharmacokinetics of antibiotics and increased susceptibility to infection. And lastly, the recurrent UTI pre-transplant can delay or complicate transplant eligibility due to the risk of post-transplant infection. What is your diagnostic work for this patient? First, you should have the urine studies, cytology, to exclude malignancy, especially if it's associated with hematuria. Imaging, of course, by renal ultrasound to assess for the hydronephrosis, stones, or structural abnormality. CT, if the upper urinary tract pathology is suspected, and voiding cystourethrogram if you suspect the patient has also associated with zygoreteric reflux. Of course, functional studies are very important in diabetic patient, including the urodynamic studies to assess the bladder function if the neurogenic bladder is suspected, and there was a post-void residual urine to evaluate for incomplete bladder emptying. What is your management strategy for this patient? The first, you should treat the acute UTI attack by antibiotic selection for appropriate duration, 7 to 14 days, because it's a recurrent infection. Prevention, of course, of recurrent UTI is very important in every diabetic patient, not necessarily preparing for kidney transplantation. You should have or you should optimize the glycemic control. It's very important. You should encourage the patient to have bladder training by time voiding to prevent stasis. Prophylactic antibiotics with the debatable role of prophylactic antibiotics. Some authors or some experts recommend using low-dose antibiotic for 6 to 12 months. Cranberry products, and we'll talk about cranberry products to prevent, as it can reduce the bacterial adhesion to the bladder wall. And in postmenopausal women, you can use vaginal estrogen to restore the vaginal flora and reduce UTI. What about using a cranberry in preventing recurrent UTI? This meta-analysis included 20 trials for more than 3,000 patients. They found that the cranberry juice and the placebo liquid were associated with decreased the rate of UTI. And the best outcome was associated with cranberry juice versus placebo liquid or versus no treatment. And the conclusion of this meta-analysis, they support the use of cranberry juice liquid benefit the rate of UTI and reduce antibiotic use, and the cranberry compounds benefit symptoms of infection. The combination of course in cranberry juice provide clear and significant clinical outcome for the reduction of UTI and antibiotic use and should be considered for management of recurrent UTI. So let's come back again. We speak about the management of UTI in this patient. There is acute management and the prevention of recurrence. Of course, we should address any underlying cause, as we see if a neurogenic bladder, it may be the patient may be considered to have intermittent self-catheterization or anticholinergic medications. If there is any structural abnormalities like stones or stricture, they should be corrected surgically. And infection control and the vaccination is very important because the patient should have the updated or the vaccination schedule to prevent or secondary infection. And of course, the multidisciplinary approach, there should be a collaboration between the nephrologist, urologist, and infectious disease specialist transplantation. So this was the first case with a diabetic patient with recurrent UTI. Professor Ayman has any comment?
Well, thank you, Professor Mohamed. This is a very interesting and very common case in our clinical practice. I have some points in this case. I would like to add to the urine studies the searching for TB. This is a diabetic patient, so we should perform routine PCR and Zell-Nelson of the urine to exclude urinary tuberculosis. So adding to the urine analysis and culture and cytology that you mentioned, we can add the PCR and Zell-Nelson for TB. The other thing that I would like to highlight, you mentioned the cranberry. Actually, it's well known and effective in the management of urinary tract infection, but we have to be cautious during using it in transplantation. There is a serious interaction with tacrolimus as it acts on the cytochrome B 450 in the liver, causing a significant decrease in the liver. It's enzyme inducer. So it's like the grapefruit also. So we should be cautious using it in transplant patient receiving tacrolimus. Otherwise, we should follow the level and increasing the dose. Also, it had an interaction with the warfarin, oral anticoagulant, increasing the effect or the action of warfarin, so we can put the patient in the risk of bleeding. So we should be cautious during using the cranberry products or juice. The other thing that I agree with you, using the prophylaxis or the chronic suppressive therapy in such patients, but at the end of the day, we should consider if all these measures fails and we still have an infected urine and chronic pyelonephritis, we should consider nephrectomy in this situation after failure of all the medical interventions you mentioned.
Thank you, Professor Ayman. Okay, we can pass to the second case.
We are going to proceed to the second case, or can we have questions from the audience
As you like,
to finish case by case? If there is any questions from the audience about this interesting case presented by Professor Mohamed? Okay, so we can proceed, Professor Mohamed, and have any questions at the end, if anyone have any questions. Okay, let's move to the second.
Thank you, Professor Ayman. Let's pass to the second case. A 35-year-old female with end-stage renal disease, secondary to chronic pyelonephritis and high-grade vascular reflux, presents for a pre-transplant evaluation. She has a history of recurrent UTI since childhood with multiple episodes of pyelonephritis leading to progressive scarring at end stage. And she is currently in hemodialysis and listed for kidney transplantation. Her most recent urine culture showed E. coli resistant, unfortunately, to trimethoprim sulfamethoxazole, but sensitive to nitrofurantoin and ciprofloxacin. And she has no significant urological interventions in the past. Again, what are the main concerns in this patient? Of course, we have a large risk to the transplanted kidney. This uncorrected reflux in the native bladder can lead to recurrent UTI post-transplant, leading to many complications. And the transplanted kidney is also, due to the use of immunosuppression, has a high suspicion to infection. The problem of antibiotic resistance complicates prophylaxis and treatment post-transplant. So this is a major issue. What about the pre-transplant evaluation and the management of this patient? Of course, it should have a thorough neurological assessment, including voiding cystohystogram to confirm the presence and the grade of the reflux, urodynamic study to assess the bladder function, including capacity, compliance, voiding efficiency, as poor bladder function may require intervention before transplantation, and of course, renal ultrasound to evaluate the hydronephrosis or any other structural abnormalities. Of course, the infection control measures, including urine culture and sensitivity, and the use of prophylactic antibiotics is recommended, low dose, of course, in the patient with recurrent UTI, especially if high-grade reflux. Let's pass to the major debate in this patient with the surgical intervention. Of course, we know the definitive correction of the reflux may be either urethral reimplantation by surgical correction or endoscopic injection of bulking agent as a less invasive for low grades of reflux. Bladder augmentation is very important if the bladder dysfunction, small capacity, or poor compliance is present. The patient should have augmentation cystoplasty and nephrectomy if the native kidney is a persistent source of infection like chronic pyelonephritis or abscess. Bilateral nephrectomy or bilateral ureteronephrectomy may be considered before transplantation. I think this case is clear. It should have, with high-grade reflux and recurrent UTI, it should have bilateral ureteronephrectomy before transplantation. But let's pass to the debate of the surgical intervention. Which intervention is better and which time, pre or post transplantation? Let's pass to the literature and then come to the discussion again. This study included 36 patients divided into 3 groups. they either underwent urethral reimplantation prior to transplantation or parietal nephrectomy prior to transplantation, or had reflux, no intervention, and underwent kidney transplantation. They found that there was no significant difference between the second and the third groups that had nephrectomy or no intervention. But the best outcome was for the urethral reimplantation before transplantation. And their conclusion was that the incidence of urinary tract infection did not appear to be altered significantly whether the patient had bilateral nephrectomy or persistent reflux. However, those patients who had urethral reimplantation had fewer episodes of infection, and the nephrectomy prior to transplantation should be performed selectively. So there was conclusion that the nephrectomy is not routine, should not be routinely performed in every case of the vesicular reflux. The patient should have high-grade reflux and recurrent episodes of urinary tract infection. Okay, which is better, pre or post-transplantation? And according to this study that compared a few number of patients, they found that after surgical correction of the ureteric reflux before transplantation, the frequency of febrile UTI remained higher than in kidney transplant without reflux. In case of high-grade reflux, reimplantation before renal transplantation decreased the rate of febrile UTI, but it's still higher than the level in the control group. So the pre-transplant correction is performed to minimize the risk of graft infection and damage. How the patient is stable and the graft is not at immediate risk, especially if low in patient with low-grade reflux. And we will discuss this after the end of this case. What about the post-transplant consideration on this patient? You transplant the patient with vesicular reflux. What is the post-transplant consideration? At first, the immunosuppression and infection risk, the patient had a high risk of UTI and sepsis, so prophylactic antibiotic may be considered post-transplant, especially in the early months, with close monitoring for the signs of infection. You should do thorough assessment of urinary tract infection every visit for this patient. And of course, graft surveillance with the regular monitoring of renal function and the imaging to detect any sign of graft pyelonephrosis or hydronephrosis, and prompt treatment of UTI early to prevent graft damage. Of course, patient education is very important. You should emphasize the importance of hydration, proper voiding habits in a regular schedule, early reporting of UTI symptoms. If the patient notices any symptoms like dysuria, fever, flank pain, he should inform his transplant physician to start treatment and diagnosis early. So this was the second case for high-grade vesicular reflux was with by recurrent UTI and recurrent pyelonephritis. Please, Professor Ayn.
Thank you, Professor Mohamed. Again, this is a very common case in our clinical practice. And you mentioned that nephrectomy should not be a routine in every case with reflux. I agree, but let's agree first that any case of reflux with chronic pyelonephritis and infected urine, the nephroureterectomy should be performed. We perform nephroureterectomy, as you mentioned, in high-grade reflux, and especially if the ureter is dilated, tortuous, and the opening of the ureter in the bladder is wide, what's called Gulf hole opening. All these are indications to get rid of this infected kidneys prior to transplantation. No way or no place for any correction prior to transplantation. We could correct before transplantation by minimal maneuvers in cases without dilated ureter, in stage 1 or 2 of reflux, and we could use the bulking material. As you mentioned, we can use silicone injection around the orifice of the ureter in the bladder in order to have an anti-reflux technique. And we should not forget the comorbidities of nephrectomy. nephrectomy, we are subjected the patient to the burden of surgery, the bleeding, collection, and most importantly, many patients get sensitized by blood transfusion after to treat hemorrhage or after nephrectomy. So we should reserve nephrectomy for infected kidneys, kidneys with high-grade reflux, and persistent presence of infection, which is persistent failure treatment. So we don't go for any reimplantation or correction prior to transplantation, either to nephrectomize or nephroureterectomy of this unit, or to use, in mild cases, silicone injection in order to preserve the kidney, to preserve the residual kidney function, the endocrine function of the kidney, to avoid any surgical complications. But in this case, it's clear that persistent UTI, high-grade reflux equals nephroureterectomy.
Thank you, Professor Ayman. We can pass to the third case. Okay. Let's pass to the third case. A 45-year-old female with a known history of autosomal UTI. She had 4 episodes of UTI in the past year, each requiring antibiotic treatment. Her renal function is progressively declining with a GFR of 18. She is being evaluated for kidney transplantation, and the patient reports symptoms of dysuria, urgency, and suprapubic pain during each episode, and during culture have consistently grown. E. coli and imaging studies revealed enlarged kidneys with multiple cysts, some of which are infected. So it is clearly an infected polycystic kidney. Actually, the polycystic kidney is associated with many diagnostic and treatment challenges. It can be presented with a typical presentation, maybe non-specific flank pain, fever, and overlap with symptoms of cyst, hemorrhage, or rupture. Localizing the infection may be difficult in many cases, and the patient should have detailed investigations, including CT or MRI, to identify the infected cyst. Of course, the treatment is very challenging in these patients, especially antibiotic penetration, as many antibiotics don't effectively penetrate the cyst fluid, making cyst infection difficult to eradicate. The resistance with recurrent UTI and the emergence of multi-drug resistant organisms, and of course, the nephrotoxicity of some antibiotics, especially aminoglycosides. How to manage this patient? The patient acutely should be managed with the empirical antibiotic till the results of culture. The antibiotic should be tailored according to the results of culture, abscess or obstructing cyst or infected cyst, and cyst drainage. If an infected cyst is identified, it can be done to give the patient antibiotic and to appropriate culture. The preventive strategies, like we said before, the prophylactic antibiotics, the behavioral medications with adequate hydrations and frequent voiding, and of course, proper hygiene, management of urinary stasis, if any large cyst or dome, and of course, vaccination is very important, especially pneumococcal and influenza, to reduce the risk of secondary infection. What about the pre-transplant consideration for this patient? Again, this patient stage 4 CKD with GFR of 18. You should optimize the renal function by management of this UTI. It can to prevent further decline in the renal function and improve transplant candidacy, address antibiotic resistance, and the debatable role of pre-transplant nephrectomy. I think this case is clear. It is a strong indication for nephrectomy in this case. But what about the debatable issue of pre-transplant? This study included 73 polycystic kidney disease patients transplanted from cadaveric donors. They were evaluated retrospectively regarding the post-transplant complications and outcomes. The patient either underwent pre-transplant unilateral nephrectomy or transplanted with their native kidneys intact. As we can see, there is no major difference in the complication, especially the infected cyst, no difference between those with nephrectomy or without nephrectomy. And the conclusion of this study was that overall post-transplant complications were more frequent and statistically significant. And their conclusion was that the graft and the patient outcomes, as well as post-transplant complications, were similar in both groups, independent of previous nephrectomy. It seems that pre-transplant unilateral nephrectomy should not be routine and has no advantage over transplantation with both native kidneys intact. Although this conclusion is limited by the small number and individualized approach should be done, especially if there is a history of cyst-related infection. So our case was associated with recurrent infection. It is a clear indication for nephrectomy in this case. But we talk about now the rule or the routine use of pre-transplant nephrectomy. And this algorithm was supposed for the management of native nephrectomy in before transplantation in patients with polycystic kidney disease. At first, are there any symptoms from the kidney? If there is no symptoms, no pre-transplant nephrectomy. If there is symptoms, is there any residual diuresis? No residual diuresis, you can do stage bilateral transplant stage or simultaneous pre-transplant nephrectomy or simultaneous if living donor. And what about the guidelines, the KDIGO and transplantation guidelines regarding the pre-transplant nephrectomy? The native kidney size in patient with polycystic kidney disease for candidate with polycystic kidney disease that is symptomatic, like recurrent patient had insufficient room for transplant. And they suggested not routinely performing prophylactic nephrectomy for recurrent pyelonephritis or cystic infection. It should be individualized. Again, our case is a clear indication for nephrectomy because there is complications, cyst abscess or cyst collections and recurrent infection. So this is a clear indication for nephrectomy. But what I want to say that it is not routine. It should not be routine. It should be individualized according to the patient because, again, as Professor Ayman said, the pre-transplant or the nephrectomy can be associated with major complications that can associated with delayed transplantation for this patient. So this was the third case. So please, Professor Ayman.
Thank you, Professor Mohamed. Again, a very common case in our clinical practice, the polycystic kidney. What shall we do for this case, to do nephrectomy or not? Let's agree that nephrectomy is indicated whether there is infection or no infection in case of huge kidneys to have a room for the transplanted kidney. So we may perform staged nephrectomy, left then right, or sometimes we remove the largest kidney and perform the transplantation, I mean in absence of infection, and to get rid from the other kidney later on after transplantation. But in cases of, let's say, instead of infection, complicated cyst, whatever the complication is, we may have complication in the form of infected cyst, hemorrhagic cyst, stones in the cyst, or even malignant tumors in the cyst. All these are indications for nephrectomy, the presence of complicated cyst detected by CT or MRI. So as you mentioned, polycystic kidney, it's not a routine to have nephrectomy unless the indication that I have mentioned. And sometimes we have a polycystic kidney that are not huge and there is no infection, and we have a room or space for the transplanted kidney. So in this case, no indication for the nephrectomy. However, we should follow up these cysts post-transplant because with immunosuppression, some of these cysts may have a malignant transformation.
Thank you, Professor Ayman. Let's pass to the last case. A 55-year-old female with end-stage renal disease secondary to chronic pyelonephritis and recurrent UTI. She had a history of multiple renal calculi, which have been managed with as-well and percutaneous nephrolithotomy. Despite these interventions, she continues to experience recurrent UTI by E. coli and Klebsiella, and her renal function is dependent on hemodialysis. She is a hemodialysis patient, and she is on the waiting list for kidney transplant. What are the key issues in this patient? Again, the recurrent UTI. This patient had a stones, and the renal calculi itself can complicate the condition because they can act as a nidus for infection and to contribute to recurrent UTI. And the patient should, of course, optimize the pre-transplantation to reduce the risk of post-transplant complications. What are the management strategies? Like the previous cases, pre-transplant evaluation by culture, imaging, urodynamic studies, and urology consultation. This is a multidisciplinary approach. You should consult your urologist to optimize the patient condition. Treatment, of course, of active infection. The recurrent infection should be treated by antibiotic treatment and maybe surgical intervention if the stone is large or causing obstruction. So the patient should be considered for definitive surgical intervention by lysotomy or ureteroscopy before transplantation. Of course, the prevention of urinary alkalization, especially in cases of strovit stone, by citrate or bicarbonate. Good hydration, of course, especially if the patient has a good residual kidney function or is not on dialysis, and infection surveillance by continuous monitoring with the culture. What about management of stones? As we see, you should have a stone analysis if you can do this to know the composition and guide the dietary and the medical management. Of course, metabolic workup if you suspect any metabolic abnormalities like hypercalciuria or hyperoxaluria, and the dietary modifications by using the diet low in sodium and animal protein with adequate calcium to reduce stones and, of course, adequate hydration. What about the post-transplant consideration? The immunosuppression should be tailored according to the patient needs and high risk of infection. Of course, infection prophylaxis, especially early post-transplant, with using the chronic suppressive therapy, and of course, close monitoring for any signs of UTI or graft dysfunction post-transplantation. So it was the last case, a case of stones with recurrent urinary tract infection. So please, Professor Ayman, and I will pass to the conclusion after this.
Well, let's agree that any case with end-stage renal disease and the native kidney are harboring stones, nephrectomy is the rule. There is no place to do or to perform BCNL or ureterolithotomy or nephrolithotomy in non-functioning kidney. These are not valid. So the rule is to remove the kidney with the stone. The other thing that you mentioned, that metabolic workup, we cannot rely on 24-hour urine collection and metabolic workup in an end-stage renal disease patients. This is performed for the potential kidney donor if they have some gravels or stones, etc. So there is no rule for metabolic workup in end-stage renal disease, no rule for any surgical removal of the stones in end-stage kidney. So if we have a patient with stones, whether there is infection or no infection, we should get rid of these kidneys because they will be a septic focus post-transplant when the patient is maintained on lifelong immunosuppressive regimen. And for the nephrectomy, in all the cases you presented, whether the uretrovesical reflux, the polycystic kidney, or the kidney with the stones, we should perform laparoscopic nephrectomy. This is a less morbid procedure, less invasive. I mean, the patient can be discharged within 48 hours. It is very easy for the end-stage renal patient, even with the huge kidney, because the kidney is cut into pieces, and I mean, it's very safe and very easy procedure rather than doing open nephrectomy. The only indication for open nephrectomy in such patient if this is a secondary nephrectomy, and by secondary nephrectomy I mean that the patient performed an operation later on previously to remove the stones, so there is adhesions and so on that make the laparoscopic nephrectomy impossible. So let's agree that laparoscopic nephrectomy is the rule unless there is a previous surgery, what's called secondary nephrectomy. Yes, Professor Mohamed.
Thanks, Dr. Ayman, for this elegant discussion. Actually, I presented a cases with clear indication for nephrectomy, but I want to discuss with you and my colleagues the role of interventions and management. But of course, all these cases should be managed by nephrectomy. It is a clear indication of nephrectomy. So let's pass to the conclusion. My conclusion, this is a debatable issue. As you see, all these cases you should manage with the multidisciplinary approach, including special urologist. So this patient should be managed in the preoperative procedure by screening, of course, for pre-existing UTI. Urological assessment is very important and it's very crucial in all these cases. Assessment of comorbidities, because if the patient is having many comorbidities, in addition to this urological problems, the patient will not be subjected to kidney transplantation. Immunosuppression risk assessment is very important. You should justify the risk for your patient and tailor the immunosuppression according to his needs and his condition. Of course, aseptic techniques during the transplant procedure, the debatable role of antibiotics, but in all the cases I discussed, it is a rule, it is a must to use the prophylactic antibiotics for 3 to 6 months by using a small dose of the antibiotics. Minimizing, of course, the use of urinary casters and implementing sterile caster insertion and maintenance procedures. The journey does not end with transplantation. It continues post-transplantation. You should do regular surveillance and follow-up of this patient. It's very important. Renal function monitoring. Again, tailoring of the immunosuppressive regimen. Education is very important by proper hygiene, adequate fluid intake, and recognizing early signs and symptoms of UTI. What about vaccine consideration? It is very important, as we said, the pneumococcal and influenza vaccination to prevent the secondary infection. But what about the vaccination against UTI? Actually, this is a study which was a retrospective single center analysis of immunization against 10 strains of inactivated bacteria. It's called Strovac vaccine. It included a total of 14 transplant patients with 3 or more UTI episodes that underwent immunization, 3 subcutaneous of this activated bacteria. And the patient were compared to another 14 patients matched for the numbers of UTI and at the time after transplantation. As you see here, the difference is highly significant. In this Strovac vaccine, there was a marked reduction in the number of UTI, while the control patients, they had an increase in the number of UTI. So to conclude, urinary tract infection and what the guidelines say, they recommend treating symptomatic UTI prior to kidney transplantation. Of course, this is a must. They suggest not routinely performing prophylactic nephrectomy for recurrent pyelonephritis or cyst infection. But again, as Professor Ayman said, there is a clear indication for nephrectomy in those patients. What else? Refer to urologist experience in the transplant issue for patients at increased risk for or those with history of. One of them, of course, is recurrent urinary tract infection. You should do a multidisciplinary approach with your urologist because these patients have high risk of kidney transplantation before and after kidney transplantation, and there should be a shared decision to have an optimal management for this patient. And thank you.
Thank you so much, my dear friend, Professor Mohamed, for this very elegant talk. Professor Ayman, would you have more comments? Or we have two
Yes,
questions?
okay. Let me comment on the conclusions. Thank you for the conclusion. And
لا هو الصوت مش مسموع دكتور أيمن بيقطع خالص.
vaccination think that vaccination against UTI. You mentioned the Strovac. Actually, the initial study that you presented in 2020, I think that the Strovac showed promising results, but there is a more recent study, I think in 2 years ago, in 2023, it was a double-blind placebo-controlled trial comparing the Strovac with the placebo. Actually, the result was not encouraging, and there was insignificant reduction in the incidence of the UTI frequency and hospitalization. But what is more recently that there is another vaccine which is called Euromune. The Euromune is, is a study that was published this year, I think in January. This was a pilot study from Spain showing a very promising results in the infection frequency, severity, and hospitalization. So I think now we are in the era of Euromune, which is shown to be superior to the Strovac. I would like to thank you very much, Professor Mohamed, for this highly informative and practical presentation. Actually, a lot of messages have been delivered from your talk, and I think also raised a lot of issues and debates and questions that we would like to receive.
بروفيسور
Professor
ياسر،
Yasser.
حضرتك دكتور ايمن على الكومنتس. بصراحه يعني بدون الكومنتس المحاضره ملهاش اي قيمه. يعني بشكر حضرتك فعلا على الاليجنت
عفوا دكتور
كومنتس، وانا
محمد.
استفدت منها كتير والله يا دكتور ايمن. شكرا جدا لحضرتك.
الله يخليك. الله يخليك.
شكرا جزيلا. ثانك يو بروفيسور ايمن، ثانك يو بروفيسور محمد، شكرا على المحاضره وعلى الكومنتس. كويستشن من الدكتور رامي ابو بكر: symptomatic urinary tract post transplant, treat or not, and duration of treatment of UTI in kidney transplant patient recommendation.
جاوب ولا دكتور ايمن؟
اتفضل
دكتور محمد، اتفضل.
المشكله asymptomatic UTI after transplantation can be associated مع حاجات كتير. يعني كان be associated مثلا مع rejection. فيعني I think والدكتور ايمن برضه هو يعني صاحب الرد. اعتقد ان الاسيمتوماتيك bacterium should not be treated in kidney transplant patients, especially if the patient has no any structural abnormalities. But we should exclude other causes like rejection, like polyoma virus, like other infections before deciding not to treat the patient.
بروفيسور ايمن،
You mean asymptomatic prior to transplantation or after transplantation?
هو السؤال after transplantation.
After transplantation, asymptomatic.
I think should be رأي حضرتك ايه، نعالج
So
ولا؟
what is the cause of this pyuria? We should know the cause of this pyuria. I mean, even asymptomatic, if there is a stone, if there is a reflux of the transplanted kidney, the reflux of the kidney actually is very, very common. And when we search for it, we will find it. But we don't perform routine voiding cystourethrogram. But if we perform routine cystourethrogram, we will find a lot of refluxing kidney, because most of the anti-reflux technique performed for the transplanted ureter usually fails. So this is a source. This is the most common source for post-transplant infection. And instead of treating, we treat the symptomatic infections, and in the presence of asymptomatic infection, we should educate the patient for the very important timed voiding. This is very important to as the surgical correction of the uretrovesical reflux of the transplanted ureter is very difficult to treat. So the only solution that we have, that we perform time voiding, not allowing the patient to have a full bladder. And if the culture is positive, we can use suppressive therapy from 3 to 6 months.
دكتور ايمن معلش بعد
دكتور عبد الباري اتفضل.
في البريد اوتوماتيك بكتيريوريا I mean
الصوت بعيد قوي دكتور محمد، انا مش سامع حضرتك كويس.
ده رامي، ده رامي ولا دكتور محمد؟
لا دكتور محمد
متهيألي دكتور محمد عبد الباري.
دكتور محمد عبد الباري.
ممكن الصوت شويه يا دكتور محمد ترفع الصوت؟
طب كده سامعني كويس؟
كده كويس.
الو كده سامعني كويس؟
ايوه كده كويس.
بقول
كده
لحضرتك لو هي يعني اسيمتوماتيك بكتيريوريا بري ترانسبلانت وعملنا لها كل الانفستيجيشن زي ما قال الدكتور محمد، بيطلع الكالتشر بتاعتها كليبسييلا وما فيش اي اكتف انفكشن، ما فيش فيفر، ما فيش رايجوس، ما فيش اي حاجه، وكفانكشنال والسيستوجرام ما فيهوش حاجه، والالترا ساوند ما فيهوش حاجه. في الحالات دي تاكسبت اور واتس ذا بلان؟
native nephrectomy should be performed to eradicate this septic focus that will be symptomatic and will florid after immunosuppression post-transplant. So whatever the cause, if there is a positive culture, persistent positive culture, and of course the antibiotic will not be excreted in such end-stage kidney, so you should eradicate this infection by doing nephrectomy.
دكتور محمد، أنا ممكن أتكلم بخصوص السؤال بتاعي.
اتفضل يا دكتور. اتفضل يا
هو
دكتور.
هو بس الديبيت اللي حضرتك بنتكلم فيه اللي هو الاسيمتوماتيك يو تي اي بوست كيدني ترانسبلانت. احنا عندنا من ضمن البروتوكول عندنا في المستشفى بتاعتي ان احنا بنعمل سكريننج لليو تي ايز يورين كلتشر بعد الزرع باسبوع و10 ايام بنعمل اليورين كلتشر. في بعض الاحيان بيبقى البيشنت عنده بوزيتيف كلتشر with significant growth. البيشنت كومبليتلي اسيمتوماتيك ما عندوش مانيفستيشنز ونورمال جي اف ار. الديبيت اللي بيبقى بيننا ما بين الاي دي ان هم دايما بيقولوا لا، يعني اسيمتوماتيك بكتيريا ما نوت تو تريت. فبعدها بشويه البيشنت بيخش بعدها في significant اي كي اي وممكن اب تو باين نفرايتس عشان الايمينو سبريشن. فانا قريت حضرتك المحاضره، حضرتك ما شاء الله يعني محاضره رائعه واستمتعنا بيها كلنا. بس أنا سؤالي بخصوص بقى الاسيمتوماتيك بكتيريا، هل استنى لغايه ما هي تبقى سيمتوماتيك والبيشنت يخش في كومبليكيشن، ولا طالما يعني تريت اور نوت تريت في الاسيمتوماتيك بكتيريا؟ ده السؤال. يعني انا برضو هانفستيجيت كده كده هانفستيجيت، لكن السؤال انتي بايوتيك تو جيف اور نوت تو جيف. والسؤال الثاني اللي هو بخصوص الديوريشن اوف انتي بايوتيك. يعني على حد ما انا فاهم ان الترانسبلانتد بيشنت بنعتبره كومبليكيتد يو تي اي. الديوريشن بتاعت الكومبليكيتد يو تي اي اب تو 2 ويكس. فحضرتك برضو رايك بخصوص التريتمنت بتاع اليو تي اي لو افترضنا ان في بيشنت عنده يو تي اي، ده يعني انذر كيس سيناريو، بيشنت عنده اوريدي يو تي اي، الديوريشن بتاع التريتمنت 5 days السمبل يو تي اي، ولا هتعتبره كومبليكيتد وتستندد ديوريشن اب تو 2 ويكس؟ شكرا جزيلا.
تمام. شكرا دكتور رامي. انا الدكتور ايمن جاوب على النقطه دي بوضوح، يعني قصه الاسيمتوماتيك بكتيريا بوست ترانسبلانت، واعتقد هو زي ما هو بيقول فعلا لو في اي يعني ريفلكس او في اي ستراكشر ابنورماليتيز. بس طبعا يعني انا متفق معاك ان فعلا الريسك اوف يو تي اي بعد كده حتى لو ما اتعالجش هيبقى عالي. فانا رايي ان العيان لازم تكسكلود ان في حاجه سيرجيكال او في حاجه اوبستراكتيف او حاجه زي كده. ولو فعلا بدا يظهر فيه سيمتومز يشود ستارت ايرلي، بالذات لو في ريكورنس كمان، او ايرلي كمان لو في ريكورنس كمان بوست يعني بري ترانسبلانت. الديوريشن طبعا انا يعني متفق معاك، ده طبعا في اناتوميكال ابنورماليتي فده يعتبر كومبليكيتد يو تي اي، فده شود بي مانجد فعلا لمده 14 يوم. ده فعلا انت عندك بالفعل انت عندك اناتومي مش ده الاناتومي الطبيعي. فانا متفق معاك في قصه الكومبليكيتد يو تي اي دي تماما يعني.
هو ده يعني ما يختلفش عن البراكتس اللي احنا بنعمله، ان هو
مظبوط.
عادة اسيمتوماتيك بكتيريوريا في ما دام
تمام.
بوزيتيف كلتشر يعني في الترانسبلانت يوجوالي جو تو تريتمنت
مظبوط.
في ذيس بيشنت عشان يمونو سبريشن. اوكي. سؤال من دكتور
خلينا
محمد. اتفضل يا دكتور ايمن.
نقول انه الديبيت في الاسيمتوماتيك vaccine the immune competent patients we may debate, but in immune compromised patient we should treat, otherwise زي ما انت بتقول هيجي بعد كده بايلونيفرايتس وده اللي بيحصل. So positive culture in immune compromised patient we should treat. There is no debate in immune compromised patient. We should treat for at least 14 days, and then for that have been catched as sensitive in the
طيب هو الصوت مش واضح يا دكتور ايمن، على ما يرجع الصوت تاني او
طب
الانتركونكشن.
الصوت ما كانش واضح الإجابة؟ الصوت كده واضح؟
لا يعني اخر جزء منها ما كانش واضح.
ال ال
يعني هو حضرتك قلت ان احنا
What I want to say that the debate in the immune competent patient, but in the immune suppressed patient, there is no debate. We should treat. We
Yes.
should treat the positive culture for at least 14 days, and then 3 to 6 months with chronic suppressive therapy.
Okay. Question from Dr. Mohamed Abdel Bari. Case of female in post-menopause with persistent asymptomatic bacteriuria with no active infection prepared for transplant. يعني هنا pre-transplant. What investigation would you add more and management pre-transplant? الحلقة.
The culture is negative. I mean, this is sterile pyuria, or it should
Asymptomatic, no active infection. No
no
active.
I mean, this is could be a leukocyturia. Yeah, I mean, or this is there is an organism and positive
هو I think no active
culture,
infection معناها ان الكالتشر نيجاتيف.
or
I
this is
think يعني.
sterile pyuria, or
I mean دكتور ايمن I mean ان في اورجانيزم، بيبقى في اورجانيزم بس ما فيش اكتيف انفكشن، يعني ما فيش فيفر، ما فيش رايجوس، ما فيش بين، ما فيش ديستوريا، وهي اساسا اند ستيج وعلى داياليسيس وبريبيرد فور ترانسبلانت. بنفاجئ
again, Dr. Mohammed, if this is a
زي ما
case
حضرتك قلت
which is not going to be transplanted, the situation,
Septic
and
focus.
patient will be transplanted, the situation 10. Septic focus not eradicated prior to transplantation and is going to receive lifelong immune suppression, we should get rid of these infected kidneys.
اوكي تمام.
By nephrectomy. Bilateral.
Bilateral.
Okay. Okay, no more questions, no more chat. So we can close. Professor Ayman, please.
Well, I would like to thank Professor Yasser in the beginning for his, as Professor Mohammed mentioned, enthusiasm and great effort in the CME all over the year and during the EST conference. Actually, thank you, Professor Yasser, for your huge and persistent effort in this field. I would like to thank Dr. Rami for the perfect coordination, and thanks Professor Mohammed for this again elegant and practical, very practical actual presentation that we always need rather than going to the pathophysiology and mechanism and pathogenesis. I mean, this is a more palatable presentations with a lot of clinical messages, and that's very, very important and useful in our clinical practice. Thank you very much.
احنا اللي شاكرين يا دكتور
Thank you, Professor Ayman.
كنا محظوظين بوجودنا مع حضرتك فعلا، احنا استفدنا والله كلنا من اليوم يعني. شكرا جدا
شكرا
لحضرتك.
جزيلا. شكرا.
شكرا. Thank you, Professor Ayman, for leading this session, and special thanks to Professor Mohamed Nassar for his usual great presentation, to the point and simple, to the point and very illustrative presentation targeting the most important items of the topic. And thank you, my dear friend Dr. Rami, for all of your work and for also your interaction during the session. Thank you. Excuse me to close, and تصبحوا على خير والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
شكرين. كل سنة وانتم طيبين. شكرا. مع السلامة.